For our final session, we have a very exciting presentation by Dr. Tania Renna, Associate Professor at the University of Toronto, Department of Anesthesiology and Pain Medicine, and currently the Medical Director of the Toronto Academic Pain Medicine Institute, TAPME. TAPME is the comprehensive interdisciplinary academic pain program serving as the hub for chronic pain care in Toronto. Dr. Renna practices anesthesiology and chronic pelvic pain at Women's Health Hospital. She served as the co-chair of the HQO Guidelines for Chronic Pain and is currently the co-chair of the Ontario Chronic Pain Network and the Ontario representative for Pain Canada, and most recently named as the president-elect of the Canadian Pain Society. What's particularly exciting for me as a female is to see evidence coming from physicians on the female population, as we know, often neglected in research studies, and often what we see is pain being overlooked in this specific population. Dr. Renna has worked in this space for many years and has pushed the boundaries of what we understand in women and pain. Dr. Renna's presentation will focus on the potential role of cannabinoid-based medicine in women's health, in particular in the context of pain management in women suffering from pelvic pain. Welcome, Dr. Renna.
Thanks so much. Thanks for inviting me. Thanks. All right, so I look so angry in that picture. I'm really nice. I'm here to talk to you about women's health and pelvic pain and the potential role for cannabis. I just want to make you understand kind of who's impacted by pelvic pain, the magnitude of the problem. Learned about some gender disparities in healthcare, review some management options, and maybe understand how cannabis can play a role. So I'm lucky enough to work in a very big group of pain physicians and health disciplines. So I work with a lot of different health disciplines. We run interdisciplinary pain programs at our central hub at Women's College Hospital. And then I have the luxury of working with all kinds of people who work in pain, like Dr. Hans Clark, who runs the transitional pain service, amongst many other things. But I have the luxury of working with people who work in substance use disorders and neuromodulation, intravenous ketamine, and cancer pain. So we really provide kind of all types of pain care at TAPME. I'm very proud of our program. I've been doing pelvic pain for a little while, almost out of necessity because nobody else was willing to do it. I see 460 new patients per year. I have an interdisciplinary team with a psychologist and a physio. I have about a 6-month wait list, and we got smart enough a couple of years ago to create something called empowered waiting modules. So while people wait for care, we give them information about what kind of services they can reach while they're waiting, what kind of exercises they could do, things like pelvic physio, and a variety of information that the patients can use while they're waiting, because patients will go down a rabbit hole. They'll start Googling all kinds of stuff, and we want to make sure that the resources are trusted. And I also have a 7-week interdisciplinary program that I run with the pelvic physio and the psychologist. So knee pain is interesting. I wish I did knee pain. I had one knee pain patient the other day. It took me 15 minutes to do the consult. It was wonderful because if you have knee pain, you can basically touch it and move it and exchange stories with your coworkers, and you can explain why you're walking funny or disabled. But when you have pelvic pain, right? You can't really do things like this at work, right? Because you'll have an HR complaint for sure. And as much as we'd love to laugh about it, it's pretty sad to me, because what happens is these people feel really isolated and embarrassed that they have pain that's maybe 2 feet away from their knee, and they can't talk about it, and they can't rub it and show you or tell you how it happened. So it adds to the pain because they get anxious, they get frustrated, and so they actually have increased pain just by mere virtue of where the pain is. And so you wonder, why do people with pelvic pain suffer so much? It really impacts everything, and we'll talk about what the definition of CPP after. But when you think of how pain perception happens, it goes from the peripheral nervous system to the central nervous system, and it goes to the thalamus, and then from the thalamus to an area called the somatosensory cortex. So a bit of a graphic image, but the understanding that your somatosensory cortex is where the body map exists. And a huge part of your somatosensory cortex is consumed by the pelvis. And so even if you have a small pinpoint area of pain, the way your brain perceives your tip of your penis, your labia, your genitals, your hip and pelvis is huge in the somatosensory cortex. So very big mapping of your body, your pelvic area. And so that's why they suffer so much. And there's probably an evolutionary mechanism as to why this is so. It's probably because if you're having pain in your genitals or your pelvic area, that this might impact your fertility, it might impact your ability to carry a child or have a baby, and it might impact bipedal locomotion, is why we evolved to be walking. And so there's a good reason for why your brain makes a very big deal out of pelvic pain. And so I want to define pelvic or pain for you, and it's an unpleasant sensory and emotional experience. So it's two things. It's a sensation and it's an emotion, right? And we're really good at trying to measure the sensation part, but we get, as clinicians, we don't do a good job of measuring the emotional part. And so chronic pain is pain that lasts for longer than 3 months, and it happens in 20% of the population. So when my patients are telling me they have pain, they're telling me they're being warned that something dangerous is going to happen, that they're being threatened. And so there's more to just that definition. It's through people's life experiences. That's the highlight to the new IASP definition of pain, of chronic pain, is that it's not just motor nerves. It's like your life experiences that you learn the concept of pain. And not everyone has the same life experience, right? You could have had a very easy life and be perceiving pain from a hip fracture or hip surgery, and then have had a very complex life where you were consistently threatened and in danger, and maybe perceive that pain differently or worse. So it's not the same race, it's not the same pain, okay? So the chronic pelvic pain, there's the definition of it. It's kind of a boring definition, but it really impacts people's sexual and emotional behavior. And this is important because sex is a measure of function. It's a measure of vitality. And so when that starts to go away, it definitely impacts people's emotion, their mental health, their physical health, and their social circumstances, because people are more likely to get a divorce and not be able to have a good quality partnership with anybody. And there's also this element of abuse. So 39% of females with pelvic pain have a history of sexual abuse. I think it's a lot higher. Like in men, it's a smaller percentage, but I think it just goes underreported, which is even more sad. So males are more likely to report physical and emotional abuse than they are to report sexual abuse. So there's also a heavy psychological overlay. Now, pain in women, 70% of all chronic pain sufferers. So of that 20% of the Canadian population that has chronic pain, 70% of that 20% are women. And so this is a big deal for me, because we have to ask ourselves, like, why? Why are so many women having more pain than men? What I see more often is endometriosis, so a huge portion of my population is endometriosis. And when I do see males, it's usually prostate pain syndrome. But the commentary about women having pain, I just wanted to highlight endometriosis, which is what I see all the time. But it's a painful inflammatory disease, and it presents with cyclical pain that they start having when they start their menses. But it takes 8 to 10 years to get a diagnosis. And I put that 3 times on purpose because that's huge. Like, by the time I get to see them, there's not really much more I can do for them because they're so centrally sensitized. So we're starting to look at more preventative things or diagnostic tests that are really for women because we're not small men. We're different. And there are significant gender disparities in medicine. We've seen that. I've seen that in my own house, right? I came to TAPME and 70% of the patients are female, but 90% of the providers are male. And I have great allies in our group that really help me do what I have to do. But at the same time, it's a different perspective when you're a female. And so one of my friends, Bradley Kerr, told me that he just recently switched. He's a basic scientist. He just recently switched to female mice, and the outcomes of some of their experience are widely different. So when we do initial trials in male mice and female mice, lo and behold, they're very different. And we've seen, this gender disparities in medicine all the time, right? We know that if you're a female, you're 7 times more likely to be discharged from the emergency room while having a heart attack. We know this cardiac data, which is crazy. And that said more than what, but I think it got censored. Women wait longer than men to receive pain medications in the emerge. We wait 15 minutes longer, that's the average. And we're half as likely to be treated with pain medications after having a cabbage. So you can have a male cohort and a female cohort, and the males will more likely be treated for their pain. And medical conditions in females are more likely to be diagnosed as anxiety disorders, and there's significant data around that. And I know I'm complaining, but I have to. You guys gave me a microphone and invited me to talk, so that's what I'm going to do. And so I have this call to action everywhere I go to make people understand, hey, like, this is an isolating problem. You know, let's let people talk about it. Let's, you know, make people comfortable. I know it's awkward, but at the end of the day, if we could talk about it, then we can look at how to manage it. And we know it's more common in females. We know it's more common in abuse survivors. And we know there's a lot of disparities in healthcare. So let's try to study things on women specifically. I have the 3 Ps for pelvic pain management. They're pelvic physio, psychological therapies, especially trauma therapies. So cheers to you, Wendy. I just met a previous trauma therapist. Everyone go to her today. And then pharmacotherapy. And so this is my pharmacotherapy plan in 2009. And then I have the same pharmacotherapy plan in 2024. And this made me so mad because I realized no pharmaceutical industry is putting out any new meds. They're probably just afraid from the produce scandals and the opioid crisis. And it's really a huge disservice to the patients because I have nothing good to offer them. And so my patients have been trying to tell me about cannabis for a very long time. And admittedly, I was always scared of trying new medications, et cetera, for patients. But you have to listen to the patients, especially female patients, because there's not a lot of studies done on them. And so they're trying to tell me about what's helpful for them. And we know more and more women are using cannabis in Canada. Significant increase in percentage of women using cannabis over the last several years. 23% of women in 2020, and this is a survey done in Canada. And we know that a lot of women are using cannabis for chronic pelvic pain. So another survey done out of the Mayo Clinic in Florida showed a significant number of people are using cannabis, and they're reporting a significant improvement in symptoms when using cannabis. And so they're using it. That's the bottom line, is that they're going to be using it anyway. So a systemic review in 2022 highlighted the fact that women are using it and they're getting some pain relief. And so we can't interpret all this data like with all the other data about cannabis. It's because there's such a variety of cannabis formulations. And so what are we as Canadians telling our patients about cannabis? This is an article written by my friend. It's actually guidelines that come out of the SOGC, the gynecologist group in Canada. This is one of my friends, Magali Robert, out of Alberta. And they're writing recommendations with regards to cannabis. And it's, you know, pretty useless for me because they're telling patients not much, and that women should be counseled about the lack of evidence for using cannabis products to treat chronic pelvic pain. And I just find that offensive because so many of my patients are using it anyway, and they're telling me they're having good results. And so, you know, to make that as a guideline, I just think we're not doing enough like we keep doing. We just keep dismissing what the patients are telling you. Like a quarter of them are telling you, listen, I'm using this stuff and it's working for me. And then, you know, we go and create guidelines that say, we have nothing to tell you, instead of actually studying it. So my patients don't use oil or capsules or vape it or whatever. They actually use rectal suppositories. A huge cohort of my patients were telling me they were making it themselves, and they don't understand. Like, you know, they get these DIY concoctions off of the internet, which is what a lot of women do when we don't know how to, you know, manage our symptoms. We go to the internet and then we get influenced, like people with like Gwyneth Paltrow, and do all kinds of stupid things, and then we create our own cannabis suppositories. So I just wanted to, you know, and this is kind of the last time I was like, oh, when I first found out, I was like, oh, cannabis suppositories, brilliant. Let's look at all the studies about cannabis suppositories. And then I looked it up, and the last time was 1889. So really cool, the use of belladonna and cannabis indica by the rectum in gynecological practice. It's the last time we studied it, and so we got to get back on this horse, right? Like people were doing this a long time ago, and we were really missing the boat. And so I just wanted to give a quick shout out to Avicanna, because one time at a Christmas party, I was just talking about how my patients are telling me they're making their own cannabis suppositories. And lo and behold, I got a tap on the shoulder in email, and then there it is on the MyMedi website, some cannabis suppositories that we're trialing out on our patients now. So really exciting stuff, just the beginning. But I mean, my patients are talking about it. Everyone's getting excited about cannabis suppositories, and there's options here with THC or with no THC. So we're going to do the studies together to figure out what is the dose that's required and the frequency, because like I said, the last time we were looking at this was 1889. So it's funny how things circle back, right? So my guess is the patients really find relief from this because of the evidence for cannabis use in spasticity. And so when you look at the differential diagnosis of chronic pelvic pain, no matter, there's 70 things in the diagnosis, and no matter where it starts from, you end up with the same thing, right? You end up with this, I call it my hot boiling pot of meat, which sounds gross, but it's an inflammatory process, and once you get it on the bowels, on the bladder, it starts giving you IBS symptoms, it starts giving you painful bladder syndrome. So they kind of create these overlapping conditions. And so the whole pelvic floor becomes super tight. And if your pelvic floor is really tight, you're going to get constipation, you're going to get incomplete bladder emptying, and so you're going to have this slew of overlapping conditions that develops from one condition in the pelvis. Not a lot of parts in the body work that way. Your liver and your knee don't talk to each other, so organs and visceral structures and somatic structures don't really talk to each other, except in the pelvis. At the level of S2, 3, 4, there's a somatic and visceral convergence. So the muscles of the pelvic floor have to talk to the organs in order for you to have coordinated bowel and bladder movements. So there has to be that crosstalk, but this crosstalk and pain becomes very dangerous. So my impression is that from the cannabis suppositories, they're actually giving themselves this pelvic floor relaxation. They're able to defecate, able to empty out their urinary bladders, and so you're getting these great outcomes with not just pain relief. Because you can imagine something constipating like an opioid is going to not be very good for somebody with an abdominal pelvic pain disorder. So this is a great option for patients. And so I think it works just as good, and we'll compare it to pelvic floor physio. I don't want to take the physio job out, but I think it's additive and it keeps those results going. And that's what I'm starting to see in a lot of my patients, that if they're responding well to pelvic floor physiotherapy, which is really invasive, they might respond really well to the rectal cannabis. Now listen, we have to do things with really, we have to learn from the mistakes of the opioid crisis. We have to get all the knowledge that's really geared towards women, if we're using it for women. Women have estrogen, more estrogen than men. And so we know estrogen is pronoceptive, right? It makes you perceive more pain. And testosterone is actually anti-nociceptive. In animal models, it makes animals perceive less pain. So we have to kind of understand what are the influences here in making in people's pain relief. We have to understand their impact on fertility, because we have to be asking the question, are you having a baby? If you're not planning on having children, then we don't worry about the fertility aspect, but we should still be studying the impact of things like cannabis on fertility. We should really arm our patients with as much knowledge as possible, and we really need to address those gaps in the literature about women, about fertility, about pregnancy and cannabis use. And we also have to consider the data on how it's being consumed, because we have some data about inhaled cannabis, but nothing about rectal suppositories or suppository delivered medication. So I think we're really going to start answering those questions. So thank you guys for creating that product. I'm a bit I've become a bigger advocate for cannabis because no one's giving me anything else, and because my patients are having really good results. So I want us to consider the person, being female, consider the risks, us having to engage in parturition and being pregnant. So consider those risks of people using it during that time. And as always, include women in the discussion. Like I always say, we're not small men. And that's it. If anybody has any questions about their own pelvic health, come, I'll let you talk about it freely.
So we do have some time for any questions if anyone would like to jump up there.
And if you don't, I understand you're embarrassed. Don't worry about it. It's probably additive to your pain perception. But yes, Dr. Bell.
Thank you for a great talk.
You're welcome.
The suppositories, can they be used rectally or vaginally?
Correct. Beautiful. Love that question. So smart. You're so smart. You should do something. Yeah. So we started using suppositories vaginally. So the way the pelvic floor works is that a lot of the muscles that encircle the vaginal opening actually encircle the rectum too. So when you put stuff in the vagina, there's no sphincter, so it's hard to hold in. So you have to be lying down, you have to be sitting on your side, and you have to wait to get some absorption. Because the rectum has a sphincter, then it can hold it in and you can actually do stuff. The other benefit to putting stuff in the rectum, you'll get the same muscle relaxation in the same muscles, is that men have a rectum and not a vagina, so it's kind of easier to prescribe them for both sexes. And then the other part is that the female vagina is, it's really hard to put stuff in it without changing the pH and getting subsequent yeast infections. And so we're finding, even with other medications being delivered in a suppository form, that when women will put it in the vagina, they would get other infections because they're changing the pH of that flora. But if a female tells me they get good benefit from putting it in the vagina, I'm like, however you want to use it, but this is also considerations for a study. So thank you so much for giving us that idea. Thanks.
Just a question around those two ratios. Have you seen any benefit with the CBD dominant versus that? I think it was a 1-to-3 or maybe 1-to-4.
Right.
Yeah.
Do you know what? I have to be honest with you. I'm getting good results from both, but it's the older people that don't want to do the THC. So when I have a vulvodynia patient that's in their 70s or 80s, which is usually when vulvodynia happens, so that's this irritation, this kind of small fiber neuropathy that happens around the vulva because it's so hyper sensitive. They really like using the CBD. They asked me for the CBD product only, and when I asked for them, I said, "Do you have a CBD product only?" They delivered, so we'll see. We'll see if. But I'm not seeing any difference. I'm seeing it more for patient preference.
And any difference in tolerating, like as far as taking THC rectally? Much concern for impairment, or is it pretty well tolerated?
It's pretty well tolerated, which is why the method of use has to be an important thing to study, right?
And then last one, just any specific diagnoses where you're like, yes, this is a common theme, whether it be endometriosis or the vulvodynia, like anything specific that seems to have great results so far?
Proctalgia fugax, have you ever heard of that? Or levator-ani syndrome? People who get this kind of thunderclap pain in their rectum. Usually if they've had perirectal surgery, colon cancer, that type of thing, we've seen it work quite well for rectal cannabis suppositories in that PRN way.
Awesome. Thank you.
Yeah, you're welcome.
Hi, my name is Chiamaka. I'm a nurse practitioner. So my question would be topicals.
Yes.
And more related to, let's say, breastfeeding moms, right? I've been kind of playing around with that in my head, and I don't know where to look for information on that. So if a breastfeeding mom wanted to use, let's say, even topical CBD creams for pain management, what would you say to that individual?
As long as I give them the warning about the lack of evidence, which I think is like such a cop-out too, I would, if they're going to consume it, they're going to use it anyway. So I feel like I would be okay with that. It's just depending on where they're putting it. So I don't use any topical components around the vulva or the vagina because of that pH sensitivity. But I haven't, I don't know too much about the topical data with pregnant and breastfeeding women. So that's why that kind of route of use has to be studied, because we're just kind of blanketing everything, right? We're saying, yeah, don't use it when you're breastfeeding or you're pregnant, but we're not really looking at the way people are telling us they're using it. Right?
Thank you.
You're welcome. Anybody else? Dr. Clark, did you put your hand up? Or you were giving me a thumbs up? Oh, okay. All right.
Well, thank you very much for that great presentation. And I know that we at Avicanna have always studied, even in the preclinical models, and made sure to have both female and male rats. And actually, today I got notice of a publication that both has the female and male rats being investigated for different cannabinoid receptors and their sensitivity. So it also speaks to, at the preclinical level, how we have to start to understand the tolerance of THC and CBD and its effectiveness. And we do see different concentrations being used in female and male populations. And what's in our MyMedi platform, it's almost 50-50 of users, male and female. So there's a lot of research, and I hope that Health Canada thinks about that tax incentive to help researchers like Dr. Renna, Dr. Clark, Dr. Bell, and so on, to be able to conduct these studies, whether it's randomized controlled trials, but also at the preclinical level where we still have a lot of understanding.